Welcome to Untold Physio Stories podcast, your perfect commute resource with physio failures, successes, interesting cases, and more from the physio and rehab world with your hosts, Drs. Andrew Rothschild and Erson Religioso. Topical analgesics help patients alleviate pain and reduce discomfort. I recommend and use Helix Professional Pain Relief Creams with my patients. Helix has 3 new creams they've added to their line of topical analgesics. Joining their pain relieving cream is Triactive Therapy Cream, CBD Therapy, and CBD Clinical Creams. My patients have been raving about these creams, and that's why I'm offering you an opportunity to try these in your practice. Email my exclusive promo code MMT2 to Helix at helix4pain.com to receive samples of these new professional pain relief creams and find a medical supply distributor near you. You'll get a starter kit with several samples, patient information brochures, and it's a great way to help patients and grow your practice. Welcome back to Untold Physio Stories podcast. I'm one of your hosts, Dr. E, with Modern Manual Therapy, the new private network, The Eclectic Approach. Make sure to check that out. It's modmt.com/members. And of course, Edge Mobility System, my co-host, again, missing in action, but I have one of my favorite guests, Dr. Malik Parker, back with us today. I don't know if you guys remember, but Malik is one of my genius mentees who basically figured out a hip case with a crazy directional preference that I don't think I would have gotten to, but now I think about it. So I'll be sure to link to that one in the show notes. How's it going today, Malik?
It's going well, Dr. E. Thanks for having me on. You definitely oversold me with that. I just test things until they work. Sometimes I look good. Sometimes I look crazy.
Right. Well, we have your successes on here, and you also share them on the new network. So I appreciate that. So what do you have for us today?
I just wanted to talk to you about something that I noticed recently with a couple patients, and they didn't necessarily come in for this. So it was kind of just something on the back of their minds and maybe that we would think about later. But last week I was treating a patient actually for her lower back into right hip, right knee, difficulty with stairs. And we were doing well with right side glides. So when she came in, she was like, yeah, I'm doing pretty well with that, but I have this thumb pain, if we could look at that. And she had mentioned it before, but it's something that, we kind of glossed over for maybe a later visit. And since her, normal complaints were doing okay, I was thinking about a patient I had a couple of weeks ago who actually responded to retraction. So bilateral thumb pain, diagnosis of like bilateral decurvains, getting like cortisone injections. She was even getting PRP injections, just trying to figure out something to help. And I just decided, why don't we just test the neck and try some repeated retractions? And within 30 reps, both sides were able to abolish. So it made me think of a couple different cases I had. I had one 2 weeks ago, same thing, and then maybe a year or so before that. So I wonder if you've had any bilateral thumb pain, right kind of in that, that typical anatomical snuff box decurvains area, respond to retraction.
Simple cervical retraction? No.
Simple cervical, yeah.
I mean, I guess it's possible that I didn't ask. Would you treat like the Republic of Gamers or something? Like, what is up with the bilateral thumb pain?
And they were all, this is a very small sample size, but they were all maybe like 50 to 70 older females. So there's no real, I don't know. And
I wonder if it was something like crocheting or something that you do for a prolonged period of time in a flex position. No, I mean, I haven't seen that. It's one of the first things I check anyway. Would be cervical retraction. And I guess if it was bilateral, I wouldn't be biased to load it one way or the other. But no, I haven't checked it. But there you have it. I mean, if you see anyone with a diagnosis of bilateral decurvains,
especially bilateral, usually that's especially the red flag, right? It's like, well, if there's got to be something central going on. Most likely, in most cases, even if one is stronger than the other, usually one is like more pronounced than the other, but they both seem to respond in all 3 of those cases, at least.
Yeah, that's great. Were they happy?
They were happy, yeah. And they were just like,
Were,
wow, this is all I needed to do for this whole time. And I
right.
can't
Yeah.
I can't confirm because one was last week and one was maybe 2 to 3 weeks ago, and I haven't seen them for the second visit. So or
Yeah.
post doing that. So we'll see if it sticks. But
With them
yeah,
being slightly, yeah, with them being slightly on the older side, were any of them kyphotic?
yes, very much so. But their
So,
the complaints we were working on were lower back, so I didn't really dig into their neck history. So I have to see, like, did they have any concordant neck pain? The one that I saw last, she didn't have any active neck pain at the time, but she
yeah,
she said she had a history of neck pain.
yeah. I mean, the only thing this reminds me of is actually early on in my residency, way back in 1998, I had a patient um, who I'm surprised my mentor gave him to me because he was like he was a good friend of his, and also his son was like a PT student who was also ended up doing his PT degree and his PhD degree, and anyway, like he was treating him for a while for bilateral leg pain. Um, he was just doing like it seemed like stenotic. He was an older gentleman, so I think he was doing like traction and just stabilization and stuff.
Yeah,
Some manual therapy to his hips, that kind of thing. And he came to me one day, and I think it might have been even that he wasn't on the schedule, but he needed to. He had some kind of like neck pain flare up or something. So because it was like totally different, and I had room on my caseload for an eval, I ended up seeing. So I just start with retractions, and his this retractions not only made his neck pain go away, but it made this like persistent leg pain, bilateral leg pain to below the knee also go completely away.
really. I
So
don't know. That's amazing. I've never seen that. That's mm,
yeah, well, I was just thinking like we discussed it later. I remember
yeah,
with our case rounds, like, and I just said I don't know, maybe he had like a large central protrusion on his cord, or he had some sort of cord tethering or some sort of cord
yeah,
space issue, and somehow retractions just freed that up or freed up the tethering. I don't know. I mean, I still think about that case every once in a while. I've definitely
yeah.
never seen that again.
Did it completely abolish? Like that's all he did. It didn't come back, or did you have follow up? Or were there follow up
Yeah,
visits
I
where?
mean, we definitely
Yeah,
followed up because he was coming in regularly for his legs
yeah.
anyway, and just doing general
Interesting.
strengthening, and it was just gone. Yeah.
Wow. Do you think there's a possibility of just like the more pain science where you just increased the body's sense of safety so much for the upper complaints by doing retractions that it had just a generalized positive central nervous system effect?
Well, I mean, I suppose that would be a great
Possible.
modern manual therapy
Yeah.
eclectic approach explanation, which could definitely result in any improvement,
Yeah. Yeah.
definitely being non-specific. But here's the thing: in 1998, pain science wasn't invented yet, and I was 100% pathoanatomical in all my explanations. But it's
Yeah.
not even like I sold the idea of uh, manual therapy non-specificity and any of those things. It was a total accident. I was just doing retractions on him with maybe a little bit of overpressure, and he was just talking about how his leg pain was like going away that he currently had as I was doing it.
That's awesome. Well, were you so posture wise, maybe being in? I'm assuming he was probably in an upright, slightly lordotic posture. Do you think maybe the
Yeah,
prolonged just sitting in that position could have also been a contributor?
it's possible. I mean, I don't know
But
what my
yeah,
mentor was exactly doing until then. I don't know if he was just doing a lot of flexion-based things, assuming it was stenosis,
yeah,
but so it's very possible that he just also was in an extension position for both, or at least less than total
less
flexion.
than normal. Yeah,
Yeah, yeah. So I don't know, and
that's
I didn't mean to
you. You
co-opt your episode, but I mean
oh no, that was a
it was another bilateral extremity case that got better with cervical retraction.
that's a great one. You take the award right now for most interesting reduction or derangement reduction case.
For sure, for sure. Maybe the Mackenzie Institute will have me back.
Yeah, you gotta submit, write it up and submit it.
Sure. All right, Malik. Well, where can people find you?
Right now, you can find me at Malik Parker DPT on Instagram, and hopefully, I'll be more active on social soon.
All right. It's always a pleasure having you on. Thanks for coming on.
All right, have a good one.
Yep. All right, guys. If you like this episode or you have any kind of crazy physio failures or interesting cases, make sure to hit me up on social media at Modern Manual Therapy on Facebook, Instagram, and YouTube. Subscribe to this podcast wherever you listen to podcasts on Apple, Spotify, or Google. Give us a 5-star rating. And as always, you guys have a great day.